Well, thank you all so much for attending. We're really excited to have you guys all participating and really excited to have Dr. Sellinger here with us tonight to kind of walk everybody through Confirm MDX and the genomic prostate score. I know Dr. Sellinger really doesn't need much of an introduction, but for those of you that aren't aware, he's current president of the Advanced Urology Institute, a big, large LUGPA down in the South. He's also the current secretary of LUGPA, and also faculty for Grants Rounds of Urology. So with that, Dr. Sellinger, I'm going to turn it over to you. Let me make you the host so you're able to share your screen. And it's all beautiful. Thank you. All right, it's all yours, Dr. Sellinger.
All right, let me go ahead and pull up the presentation here. Hopefully everybody should be able to see this here. How does that look? Are we good?
Looks great.
All right. Well, I want to welcome everybody tonight. And again, for those of you that don't know me, my name is Scott Sellinger. I'm a urologist in Tallahassee, Florida. And I wear a lot of hats in my group. I've been in the same place for about 32 years now, but wear a lot of hats. I'm the president of our organization, of our big independent integrated urology practice. We've got about 80 urologists, close to 40 advanced practice providers now. And so I wear that administrative hat, but I still see patients every day. And one of my other roles is that I chair a committee that oversees our advanced prostate cancer patients. And we have 7 different APC centers throughout the state. And we have meetings every month to look at what we're doing and how we can do a better job taking care of these people. So prostate cancer has been an area for me that I've really enjoyed working in for the last 5 to 10 years specifically. And tonight we've got an opportunity to look at patients that we're trying to identify prostate cancer. And then the second half of the presentation will be more about patients that we know have prostate cancer and maybe how to best organize what our next steps are for them. So we're going to first start talking about Confirm MDX, the only tissue biomarker to address biopsy sampling error and identify men harboring clinically significant prostate cancer. So this is probably an algorithm that you're used to seeing, at least in part, with precision oncology. And, you know, this is really the name of the game now, is trying to use the tools that we have in our toolbox to better be more precise for our patients and allow opportunities for better care. And so where we're looking at risk stratification, prostate cancer screening, Select MDX is helpful there. We're really not going to be talking about this tonight, but this is a urine-based biomarker that is a post-prostate massage. Usually like to obtain it within an hour or so after prostate massage. And it helps us decide if a patient is a good candidate for a biopsy or not. You know, we generally base that decision on PSA and digital rectal exam, but this gives us another opportunity to put more data points on the patient and decide if a patient needs a biopsy or not. It doesn't matter what their PSA is, can be any range. And so, I mean, typically you're going to be doing this mainly in patients that have PSAs of certainly less than 10 to 20, but any PSA level is acceptable. And so that helps us decide if we're going to do a biopsy or not. And then if the biopsy is negative, the next step there would be to further risk stratify that patient with Confirm MDX to look for patients that may be harboring prostate cancer in adjacent tissue, for example. And this may, following the Confirm MDX, gives us more information about the monitoring intensity, whether we may want to do additional biopsies or even an MRI on that patient. And then on the bottom part of the screen, in patients that do have positive biopsies, now we have an opportunity to use the genomic prostate score, which probably many of you are familiar with. Before mdxhealth took it over. It was a part of the originally Genomic Health and then Exact Sciences, and now with MDX. And really the biggest role for the GPS is in that active surveillance patient, is trying to decide, is this a good candidate for active surveillance in the low risk and favorable intermediate risk group? And then in the high risk, now we have the opportunity in the unfavorable intermediate risk and the high risk group to help us decide on treatment intensity. So this, there's a lot of unmet needs with these patients that present with negative biopsies. And, you know, the tendency there is to keep biopsying them until you've almost taken out their whole prostate gland, death by prostate biopsy, essentially. And the problem is that a standard biopsy sample really is only less than 1% of the prostate, and we do get a 30% false negative rate. The whole goal now really is, we don't want to be biopsying men to find Gleason 6 prostate cancer, one focus or two focus of Gleason 6. That's really not helpful anymore. We want to identify the men that are at the higher risk, the Gleason 7s or higher, and avoid those potentially unnecessary repeat biopsies. And if we can have a test that gives us a 96% negative predictive value for Gleason's score of 7, that gives us a lot of confidence in that first negative biopsy. Not to mention the reduced cost and the savings to the healthcare system of not having to do unnecessary MRIs, not having to do unnecessary subsequent biopsies. So it's all about methylation. And if you're really into the geeky stuff, you can look at the left side of the screen and see what this is all about with with repetitive sequencing and promoters. But the main concept here is that when cells become methylated and genes become methylated, there is a higher risk that there's going to be tumor progression of that cell where that methylation occurs. And what happens is they're silenced or turned off. Those genes are silenced or turned off, and it renders them unable to perform tumor suppressing duties. So you have tumor suppressing genes that are constantly trying to do their job to prevent cancers from developing. But when those genes become methylated, it turns them off and doesn't allow them to do their job. So what Confirm-MDx does is it looks at various tumor suppression genes, and you can see them listed here. There's 3 of them: the GSTP1, the APC cell cycle regulation, and the apoptosis gene. And then there's a reference gene thrown in for good measure. And when these 3 genes are methylated, they're all silenced, and they no longer work to suppress tumors. So let's talk first about the GSTP1. It's found in up to about 90% of prostate cancer patients, a detoxifying agent to prevent genomic damage. And this hypermethylation is clearly the most common somatic genomic alteration described in prostate cancer. So when patients have this gene methylated, it's certainly a high risk. And then the APC, this controls cell division. Similarly, when it's silenced, bad things can happen. And then the RSSF1 associated with cell cycle progression and apoptosis. So if we can measure methylation in these genes, then it can give us a better idea of patients that may have prostate cancer that may be living adjacent or nearby that previous biopsy sample that you found was negative. And this just talks about that epigenetic field effect. And we know that when we look at tumor cells that are present, that if we look in adjacent areas, either immediately adjacent or in a surgical resection area, that there's a high likelihood that we'll find these cells that have these genes that are methylated. So how can we improve the detection of clinically significant prostate cancer? And again, we're looking primarily to detect those grade group 3s and aboves. So we can look at the patient biopsy, look at the suppressor gene activity, and if positive, we can get a DNA methylation positive. That can allow us to consider repeat biopsy or MRI sooner rather than later for sure. Throw in the clinical risk factors with age, PSA, prostate volume, and DRE, and then you get that individual risk score. So really, it's independent. The DNA methylation positive is independent of the clinical risk factors, but you can throw the risk factors in to get that final individual risk score. And then if there's no DNA methylation, then routine monitoring would be the next step. So the Confirm-MDx clinical evidence, there's over 55 published studies. We don't have the time tonight to go into each of these. There's everything from analytical validation, significant savings to the healthcare system. It's all about that high negative predictive value. The higher the negative predictive value, the more likely that there's sensitivity of the test and ability to rule out those patients that do not have a clinically relevant or clinically significant prostate cancer. And in fact, it even can be broken down to 96% clinically negative predictive value for clinically significant prostate cancer. It's been validated in African American men, and there's plenty of clinical utility and actionability with all the years that it's been around to show its utilization. So looking at how does it compare to other models like the PCP-TRC model, the PSA itself, clearly Confirm MDX is a much better predictor in terms of performing as a risk calculator for identifying men who are harboring these aggressive cancers. We can look at African-American men. Confirm MDX also been shown in this study here. There were over 200 African-American men that showed a negative predictive value of 94% in clinically significant cancers. And I think that most people would agree that once you get into the mid 90% and above for a negative predictive value, that's pretty good. And your odds of missing a clinically relevant prostate cancer are really pretty low. That patient likely can really have de-escalation of investigation to look for cancer that probably is not there in the first place. So here's the report, Confirm MDX negative. This is a negative result. And if you include even the lower grade tumors in the negative predictive value, it goes to about 90%. But if you're looking specifically at the clinically significant cancers, the grade groups 3, 4s, and 5s, it bumps it up to 96%. And so a negative result gives you confirmation that routine monitoring is most reasonable next step. A positive result would lead to probably at least an MRI if they haven't already had one, and a PSA, additional PSAs and additional biopsies. You can see the example of a negative report here on the right side. It shows you each of the biopsy sites from the 12 or 16 cores, whatever you took, shows each of the methylation genes being negative, and then you get a nice little diagram there that puts it in 3D perspective for you. So what about a positive result? So this is going to definitely change what you do. And that's the other thing that I want to point out here is that I don't like to order tests that don't change what I do. If it's not going to make a difference in how I'm going to manage the patient, I'm not going to go looking for any type of molecular test, or really any test for that matter. So here's a positive result. We get the DNA methylation distribution map here. You can see the positive one on the right side in the mid portion of the gland. Just one area was positive. Throw in the other risk factors and you get a score. So here you get a score of 32% likelihood of prostate cancer upon repeat biopsy. And it would be 20% likelihood of detecting a less clinically relevant cancer, and then it breaks it down into 12% likelihood of detecting a Gleason score of greater than 7. And those are the ones that you definitely don't want to miss. So summarizing here what we've talked about in the post-biopsy setting, cancer negative biopsy, consider Confirm MDX. Is it a false negative or not? And if the Confirm MDX comes back negative, rest assured that more than likely you can follow that patient with 6 to 12 month PSAs, maybe consider subsequent MRI. A positive patient definitely needs escalation and investigation, additional PSA, additional MRI, and then certainly to consider biopsy more sooner than you might consider with a negative Confirm. This is included now in the NCCN and EAU guidelines. And remember that 96% negative predictive value for high-risk prostate cancer. So let me see, I think what we'll do is we'll take the questions at the end. It may be easier because then I can look at you all face to face there when we do that. And we can also bring in Erica to listen in and also help us with any of the questions too. So, and she says, that's a great idea because she's a really, really smart person and I love to use her as a resource. So, so let's talk now about the GPS. And this, again, is looking at patients now who do have prostate cancer. And I can tell you that having counseled literally, I don't know, I'm not so sure I've counseled thousands of men, but certainly hundreds and hundreds and hundreds of men over the 32 years that I've been in practice with localized prostate cancer or presumed localized prostate cancer. I'm struck with the fact that this is one of the most difficult decisions that they'll make in their whole life as to what to do. Should I go on surveillance? Should I consider treatment? Do I need radiation? Is it prostatectomy? What's the best option? And so many patients really struggle with this. And unfortunately, the tools that we have in our toolbox that are outside of the molecular testing don't really tell us anything about the biological behavior of the cancer. What they tell us is what the cancer looks like under the microscope and what the parameters are, such as PSA or maybe some of these other risk scores like CAPRA, for example. But as far as actual understanding the behavior of the tumor, that's what we really want to know about. And this is where we're making all these advances in this precision medicine, where we can look at the biological behavior and help make decisions. So it's another tool in the toolbox to help us. I mean, you know this information. Prostate cancer is certainly out there. Over 280,000 new cases essentially every year. Over 30,000 men die. It's a myth that men don't die from prostate cancer. I hear my patients ask me that all the time. They say, well, I heard that men live with it and they don't die from it. Well, that's true for many of them. And it's true that we don't have to treat many of them. But the problem is trying to figure out which ones are the ones that are going to be problematic and getting them the most intense treatment that we can. Unfortunately, like I said, NCCN and other risk classification schemas really are not predictive of benefit to specific treatment. We really need better precision tools. Genomics and radiomics now have been used. They can be used together. MRI is not the end of the story either. MRI is helpful, and I'll show you some data, but it doesn't really do as good a job of predicting higher risk patients, even when we compare low PI-RADS scores to high PI-RADS scores. So the molecular testing actually does a better job of that. And the other challenge in prostate cancer is it's very multifocal, it's very heterogeneous, and we'd like to be able to use tests that can allow us to take into effect that multifocality and heterogeneity. Was it the highest grade tumor that was sampled? Was it the most prevalent part of the tumor that was sampled? And we know that biopsy undersampling is a problem. These 12 cores, they don't really represent the whole prostate by any means. And this little grid here, just I think that you would say, yeah, I get this, because this is what I see. That when we do biopsies and we find Gleason 3 + 3 = 6 over there in the left mid part of the screen, and we end up doing a prostatectomy, 20% of those patients actually turn out to have grade group 2 or higher. It wasn't grade group 1 at all. And even higher grade group, 3.3%, Gleason 7 or above, non-organ confined disease, 6.1%. And we're going to use this term adverse pathology. And I'm going to say that a lot tonight. And let's just be clear on what that means right from the start. So adverse pathology is a grade group 3 or higher. And it generally is we refer to patients where we expect to find favorable pathology, but we don't. So favorable pathology would be 3 + 3 or 3 + 4. Adverse pathology would be 4 + 3 or greater, or non-organ confined. So T3A or T3B, meaning extracapsular extension or seminal vesicle invasion. So again, what I'm referring to here when I talk about adverse pathology is generally patients that we expect to find favorable pathology, but we don't. And that is one of the big hallmarks of the GPS test, is it gives us numbers that we can apply to the risk of adverse pathology in patients that we expect to see favorable pathology. So these are our tools that we have now. Digital rectal exam, not the greatest, admittedly. I would say that the vast majority of patients that I find prostate cancer on have completely normal digital rectal exams. PSA, it has its shortfalls as well. Certainly the higher it goes, the more likely they have cancer, but PSA is not cancer specific, it's prostate specific. And there's plenty of men out there with 80 and 100 gram glands that have PSAs of 10 to 20 that don't have cancer. MRI, there's a lot of potential issues there. If you're in a place where they do really a lot of these MRIs and you have consistent readings and you have good imaging people and you've got radiologists that are familiar with it, that means a lot. But even in the best of hands, It's probably more helpful in terms of extracapsular extension than anything else, not very helpful in terms of helping us decide regarding aggressiveness of disease. Biopsy and Gleason score. This is the phenotype, if you will. What does it look like under the microscope? That's what we're talking about here. That what we see under the microscope really doesn't tell us much about the biological behavior. So it's great that we have an opportunity to look at gene expression and help us talk more about the biological behavior of the tumor itself. And when we can look at abnormal gene expression, especially with this GPS test, we can look at adverse pathology, we can look at risk of biochemical recurrence, risk of nodal spread, risk of metastases at 10 to 20 years, risk of prostate cancer and mortality at 10 to 20 years. So these are nice numbers that we can look at and explain to the patient that given their test results, given their molecular testing, that they have higher or lower risk of all of these categories. So I can't tell you too much about the secret sauce of the GPS, because if we tell you, then we have to kill you. No, I'm just kidding about that. But you know, it is proprietary to some degree. But it was over 700 genes that were looked at, and then specifically looking at the whole mount prostates, they looked at 288 genes. And the whole idea here on the whole mounts was to account for that heterogeneity and multifocality of the tumor. We want genes that, whether we look at the higher Gleason pattern or whether we look at the more dominant Gleason pattern, that can actually do a good job of predicting recurrence and subsequent decline of the patient. Once that was completed, then it was carried down to the biopsy samples. And then of those 288 genes that were felt suitable on the whole mounts, they culled it down to 17 genes that looked at the biopsy samples individually. And they were able to express material as small in samples as small as 1 square millimeter, which is really quite impressive, and to look at consistent performance among the biopsy samples. And so here's what we're looking at. So this is one of the differences between this test and some of the other tests that are in this market space, is that we're not just looking at just one type of pathway. For example, cell proliferation, which is one pathway that can be looked at. This looks at 4 different pathways with 5 reference genes. So it's only 17 genes altogether. But the ones on the left, these are going to be the better outcome genes. So when these genes are upregulated or turned on, androgen signaling and cellular organization, those are favorable things that happen to the cells. When we turn on stromal response genes, cell proliferation genes, then we get worse outcomes. So it's a balancing act. And you're not just looking at ones that do bad things, but also looking at ones that do good things. And so 12 genes, 4 pathways gives you the whole profile here. So how does GPS work? This is how we would want to use it from a clinical relevance standpoint. Is basically risk stratification. We can look at these pathways. If there's a lot of upregulation of better outcomes and downregulation of worse outcomes, then you're going to have a much more favorable GPS score, and vice versa if that's flipped. And then we can throw in the clinical risk factors, pathological risk factors, and then that gives us the GPS risk assessment. So the GPS score itself is strictly based on the genetic material that's looked at, and then we throw in the clinical risk factors to get the final numbers. This helps us decide whether we want to look at active surveillance in patients that are in the low risk and favorable intermediate risk group, or if they should be better candidates for definitive therapy. And this is where I use this test the most, for sure. So if we have genes that are associated with a worse outcome on the left, stromal response, cell proliferation, and this gets a little bit into the weeds, and I'm not going to go into it any further than that, but just to show you that, again, when these are upregulated, you have either worse or better outcomes. And that's the secret sauce of the GPS test, which makes it a little bit more unique and different from other tests that are in this space. So what can we predict? So the way the test is set up, we want to be able to predict adverse outcomes. And remember, I told you, adverse pathology, men that you think have favorable pathology, but really don't. Because men you think have favorable pathology, they're going to be good candidates for active surveillance. If they've got 3 + 3 = 6, 3 + 4 = 7, maybe other comorbidities, it's certainly very reasonable to offer that patient active surveillance. We can look also at distant metastasis within 10 years, and we can look at prostate cancer death within 10 years. And I want to be clear also here that this data is in patients that have been treated with radical prostatectomy. And remember, adverse pathology is defined by Gleason 4+3 or greater or non-organ confined disease. So here's the treatment options. So we can break it down into two categories where we can use GPS plus the clinical path risk assessment to give us the final score. We can look at the low risk and favorable intermediate risk patients, which are on the top rungs here. And then the second group is the unfavorable intermediate and high risk patients, which was a later approval for the GPS. So if you've been using GPS for a while, you initially only used it in the top group. Now we can also use it in the bottom group. I told you earlier that it's really about determining active surveillance versus definitive therapy in that upper group of patients. In the lower group, it's more about intensification of therapy. These are people that we know have unfavorable pathology already. That's not the question, is whether they're going to have unfavorable pathology. They have it already. They're unfavorable intermediate risk or above. But now you're going to be treating these people. So active surveillance, again, is not an option there either. But when you treat them, especially with radiation, there's opportunities for short course and longer course androgen deprivation therapy. And this is where this has really helped me shape where I'm going to do with my patients based on the GPS score. I'll definitely extend longer courses of radiation or more aggressive radiation fields to patients that maybe have unfavorable scores on their GPS. And this is what I was just saying here now. So the GPS score gives us in that low and favorable intermediate risk group on the right side here, helping us make that determination, is this active surveillance or definitive treatment? And the validation that we have is looking at risk of adverse pathology, risk of distant metastasis within 10 years, and risk of prostate cancer death within 10 years. And this is prognostic for adverse pathology at radical prostatectomy. It's the only genomic test that does what I've just talked about here. So we can look at other predictors of adverse pathology at radical prostatectomy. And what this shows you here, and again, I'm not going to get too much into the mathematical weeds, but just to show you that if you look at model 2, the GPS per 20 units, it doesn't really get any better than that, a p-value of 0.001, showing excellent correlation with adverse pathology at the time of radical prostatectomy. And this was from Eric Klein's data, and then looking at going from prostatectomy to biopsy to the finalization of that 17 gene assay that I showed you earlier, and then prospectively designed clinical validation study where adverse pathology was the endpoint. That if you look at trying to compare it to NCCN risk group, trying to compare it to CAPRA score, trying to compare it to patient age, clinical stage, none of those do as well as GPS does, eventually helping us determine the risk of finding adverse pathology at radical prostatectomy. And in racially diverse group, looking at the differences between Caucasians and African Americans, there again was no correlation between GPS and race. So, and GPS still carried a very, very good p-value, less than 0.001, when comparing to other parameters that we commonly look at. And this just shows, I think, what you would expect to see from the 10-year risk of metastasis and 10-year risk of prostate cancer death, risk of metastasis on the left, prostate cancer death on the right. And you can look at the different risk groups going from a very low, intermediate to high, the different colored curved lines there, showing that as GPS goes up, it correlates well with the 10-year risk of metastasis, 10-year risk of death. And I'll point out, we don't really have a specific cutoff. A lot of docs will ask, what's the cutoff where I really don't need to worry in the low risk and favorable intermediate risk group? We really don't have a specific cutoff, but what we can say is that if they had a GPS of less than 20, that nobody had metastasis or died from prostate cancer within 10 years after prostatectomy. So you can use 20 as a general ballpark, but I don't think that there's really an official number that we can say that's the cutoff. Now, later on, I'm going to tell you there is a cutoff in the high-risk group. So to me, I always like to point out what I think are the most important slides in the deck. And I think that this probably, to me, is one of the most important slides that really hits home with the importance of identifying adverse pathology. And what this shows you is the 20-year data now, 20-year prostate cancer outcomes, looking at distant metastasis and prostate cancer mortality. And what this shows is these are all patients that were felt to have organ-confined disease. They were all felt to have either low risk or favorable intermediate risk disease, and they all were eligible for surveillance based on that. So these are patients that have what you think is favorable pathology going into their prostatectomy. So these are people that got their prostatectomy within 6 months of a diagnostic biopsy. And look at the amazing difference in risk of distant metastasis on the left and risk of prostate cancer mortality on the right, when you look at whether that patient actually truly did have favorable pathology or if they had adverse pathology. The low line there, the low dark line, is the group that has no adverse pathology. So they actually had what you thought they had. They had low risk or favorable intermediate risk disease. They did not have extracapsular extension. And look how well those patients do over 20 years. And that makes sense because that's what you see clinically. But if they had adverse pathology, look at the huge difference in outcomes. And so this is where I sort of look at this as my crystal ball, if you will, where I can, if I do the test on a patient that I'm assuming has adverse pathology, that I'm assuming has favorable pathology, but it turns out they don't, then this gives me a huge benefit to know that that patient has a higher likelihood, if they have adverse pathology, that they're going to have a much higher likelihood of a less favorable outcome. And those are the patients that you want to be more aggressive with. So being able to predict adverse pathology in patients that have favorable pathology, to me, is a huge, huge benefit. And I think these two graphs here really prove that point very nicely. So this, to me, would be one of the most important slides in the deck. You can also look at absolute risk of distant metastasis, 20 years on the left, and mortality, 20 years on the left, and compare that on the right to, this is a model based, it's an RM corrected and bias corrected area under the curve model here. And what it shows you is that the GPS actually does the best job with the highest area under the curve of predicting 20-year risk of metastasis and 20-year risk of prostate cancer death. And even at 20 years, no patient with a GPS of less than 20 had metastasis or died from prostate cancer within 20 years. So not only do we know that that was true for 10 years, but now also at 20 years. So what about MRI? What about GPS? Comparing those, yeah, I mean, I'm not here to tell you in any way that MRI is not helpful. It's actually extremely helpful. It's a tool in the toolbox. It's great for helping to detect clinically significant cancer. It's great for helping to detect extracapsular extension, seminal vesicle invasion. GPS on the right, the things we've talked about, being a predictor, prognostic of adverse pathology, which to me is the most important thing. Biochemical recurrence, distant mets, prostate cancer death. You'll see these reports. Those numbers are going to be pretty low, admittedly low. And so that's why I think that adverse pathology to me is the main thing I'm going to look at first. Obviously, if the distant mets and risk of prostate cancer death numbers are pretty high, you'll definitely want to pay attention to that. I think this is kind of interesting too, because, we think we do a great job with MRI of predicting, they say, oh, there's a PIRAD 4, there's a PIRAD 5, it's got to be something bad. There's a PIRAD 2 or 3, it's got to be something good. But when we compare looking at the differences between the PIRADs 2s, 3s versus the PIRADs 4s, 5s, it really doesn't do a very good job of predicting adverse pathology at the time of surgery. And it shows here that the GPS actually has clearly the best p-value, and it's the best predictor of adverse pathology when you compare it to trying to compare PIRAD scores. And especially in the favorable intermediate risk patients, it was particularly the case. So remember I told you earlier, don't order a test if it doesn't change what you do. And these doctors here all found that it really changed what they did. Active surveillance rates went up significantly when they used GPS to help make that determination for their patient. And when you didn't use GPS testing, active surveillance rates were much, much lower. And I think now, I can tell you, I know in my practice, the active surveillance rate for low risk patients is, above 80%, clearly 80, 85%. And a lot of that is aided by the fact that we've got molecular markers that can give us security to make the right decision in those patients. So here's an example of a GPS test. This is a patient with NCCN low risk disease. You can see that he has a Gleason 3. The print is small, but a Gleason 3 plus 3 equals 6. He had a PSA of 7, clinical stage T1C. So this is a low risk patient by NCCN guidelines. And here's his GPS score, comes in at 30, which is on the right side of the bell curve for his cohort in the low risk group. And what the score does now is it gives you that 30 likelihood of adverse pathology at radical prostatectomy. It's just coincidental, by the way, that the GPS is 30 and the percentage is 30 here. It doesn't, that's purely coincidental that number happens to be the same, but puts him in that moderate likelihood category. And I want to be clear here too. This test is not going to tell you to put a patient on surveillance. It's not going to tell you to put a patient on active intervention. Okay. I want to be very clear on that. It's a tool to help guide you in the right direction, and it will give you basically the likelihood of adverse pathology and put you in low likelihood, moderate likelihood, high likelihood, but then you still have to make that decision of what's right for the patient. In this patient, if the median is at 28 and his score is at 30, it puts him in a little bit higher risk. And I would be a little more cautious in this patient than if he had a GPS score that was in the left side of the bell curve. And then on the second page, you actually get the numbers, the risk of percentage of adverse pathology specifically, broken down into high-grade disease versus non-organ confined disease. You can see 18%, 20%. So 1 in 5 chance that he's going to have one of those types of adverse pathology. Remember, I told you that the risk of metastasis and risk of death are going to be low because these numbers are typically relatively low anyway, after only 10 years after prostatectomy. So maybe not so helpful when the numbers are real low like this. If you see a risk of mortality that's 7, 8, 10%, that's going to really get your attention. And you will see some of those in these patients that have higher GPS scores. So here's another patient now, 62 years old, PSA almost 10, T1C disease. He's got 7 cores positive, and he's got a multiparametric MRI that shows a PIRAD 3 lesion, so middle of the road. And so he's having his counseling, and I'm not saying that I would necessarily recommend what these doctors chose to do. It's just an example of what's possible here. That this particular choice was to go with active surveillance, get the GPS back, and you see it's 32, which is on the right side of the bell curve. So it puts him at higher risk, puts him in that moderate likelihood of adverse pathology. 10-year risk of metastasis and death is still pretty low, but just being a little bit more worried here with this higher risk patient now, the recommendation was to do radical prostatectomy. And sure enough, he did have a Gleason 4 plus 3 disease. So he did have adverse pathology. And going back to that chart those graphs I showed you, it definitely will increase. That increases his risk of mortality and metastasis. So here's another patient, 58-year-old, relatively young, PSA of 5, clinical stage T1C. And so he is a favorable intermediate risk patient because he, because he's grade group 2. So he's a 3 plus 4, which puts him in the favorable intermediate risk group. And so reasonable to consider prostatectomy in this guy, young guy, favorable intermediate risk disease, but you do his GPS and it comes back very low. Risk of adverse pathology shifts him on the left side of the bell curve. And so it would be reasonable in this patient to at least start out with active surveillance. Doesn't mean he'll stay on it forever. But here's the way I look at it. If you can kick the can down the road and you're not necessarily, risking adverse outcomes later on by doing what may be inevitable, and that's a big if, I understand that. But for many patients, that those extra 3, 4, 5, 7 years, whatever it may be, before they have to have definitive therapy, can mean nearly a decade potentially of less potential side effects from treatment. And that's a big deal for a lot of patients. And the other thing is that other things can happen. Patients can die from other causes, they can develop other illnesses and so on. What about unfavorable intermediate risk and high risk patients? So this moves us into a different thought process because we're not concerned anymore about whether they have favorable or unfavorable pathology. These people all have unfavorable pathology. And so we're thinking about treatment intensification options with these people more than anything. And, what this shows here is, again, that it's an independent predictor of biochemical recurrence, distant metastasis, prostate cancer, death. And when we look at the different NCCN risk groups, and we look at the p-values and being able to be an independent predictor, they're all very, very low on the far right side there. And specifically in the unfavorable intermediate risk patient population, the GPS, and we're going to tell you that a cutoff of about 40 remains a significant prognostic factor here. That when you look at trying to look specifically at, say, Gleason biopsy, not as good of a predictor by any means as compared to the GPS. To me, this is probably that other slide that I really want to highlight that I think is equally as important as the one I showed in the low risk and favorable intermediate risk group. This is another slide that I would really like you to remember as being a predictor of biochemical recurrence, distant metastasis, prostate cancer, death. So on the left, you see what happens regarding biochemical recurrence in unfavorable intermediate risk patients. And what the GPS 40 cutoff means. So if you look at patients that have a GPS of over 40, they're going to actually behave more like a high-risk patient. So the high-risk line is the lower line. The favorable intermediate risk line for biochemical recurrence is the upper risk line. And if we look at trying to predict if a patient has a GPS over 40, their biochemical recurrence in these unfavorable intermediate risk actually behaves more like a high-risk patient. So if you look at what happens in high risk, it shows you there, and compared to the GPS over 40, those lines are very, very similar. If you take those unfavorable intermediate risk patients that have a GPS of less than 40, they actually look very similar to how the favorable intermediate risk patients look. So this is where that cutoff of 40 can be very helpful. And similarly on the right side here, distant metastasis, same kind of thing. If the GPS is, and there's a typo, I'm sorry, on this slide here, I didn't catch it before, but off to the right of high risk, it says GPS less than 40, that should be GPS greater than 40. So if their GPS is greater than 40, their distant metastasis Kaplan-Meier actually looks very similar to a high-risk patient in these unfavorable intermediate risk patients. And similarly, if their GPS is less than 40, they behave like a favorable intermediate risk. So it just stratifies risk in unfavorable intermediate risk, helps you decide, do they behave more like a high risk or behave more like a favorable intermediate risk? And I think that that's really helpful for deciding on treatment intensification. I'm going to go through this pretty quickly here. This is just some meta-analysis, clinical validation, and again, I don't want to get too much into the weeds here because I really like to focus more on the clinical aspect of this. But this was a Kaiser Permanente study. These were men with unfavorable intermediate risk and high-risk disease who had radical prostatectomy. Another group of Georgia urology cohort of men with unfavorable similar group of patients that were treated not with surgery, but with brachy and external beam. And then this VA cohort, another group of patients with unfavorable intermediate risk and high risk that were treated with external beam. And, this just stratifies, shows you in the different groups here what you had as far as the breakdown of unfavorable, intermediate risk, high risk, and very high risk, and then the median GPSs in each of these groups. And what it shows is what you would expect to see, that you see good correlation as the GPS goes up in these higher risk patients. The risk of distant metastasis at 10 years and the risk of prostate cancer death at 10 years goes up accordingly. And there clearly was an association between the GPS and these parameters. And so similar to what we saw in the favorable intermediate risk group. Being prognostic for distant mets, prostate cancer death after external beam radiation. These were 238 patients, favorable intermediate risk, median follow-up of 7 years. You can see here p-values were very, very correlative to the GPS result when looking at time to distant metastasis, prostate cancer, and prostate cancer death. So it did correlate well after patients had been treated with external beam radiation for localized therapy that for risk of recurrence. And then when looking at distant metastasis in prostate cancer death, these are cumulative. You can see that, again, where this cutoff of 40 is helpful, patients that had GPSs of less than 40, 0 to 40, those bottom darker lines, they tended to do much better, as opposed to the patients that had GPSs over 40 when I looked at distant metastasis in prostate cancer death, much higher risk. So here's an unfavorable intermediate risk patient. He's age 70, PSA of almost 9, T2C disease. So he's got bilateral disease. That's what really helps bump him into that unfavorable intermediate risk group. He's a 4+3 as well, so he's got good reason to be in unfavorable intermediate risk. So the thought here, and again, this is just one physician's concept, to prior to GPS, radical prostatectomy, IMRT, 6 months of ADT, pretty much an aggressive approach. But here we get the GPS, the cutoff of 40 is below 40. 10-year risk of Mets is less than 5%. 10-year risk of prostate cancer death is very low. And so chose to just do prostatectomy alone. And I'm not, again, endorsing any of these options here. I think what I really want you to do is think about what you might do if you knew this additional information versus what you would do leading up to it, not knowing that information. And then here's another patient now, 66, PSA of 9. And because he's T2C, that bumps him into the unfavorable intermediate risk. And this is, again, to me, this is one of the drawbacks of using NCCN risk groups. I'll admit that there's sometimes just a hair's difference between a low risk and an unfavorable intermediate risk, and a hair's difference between an unfavorable intermediate risk and a high risk. And I'll give you an example of that here in a second. But so this guy here, but he's got PIRADS 5 lesion, pre-GPS recommendation was, we need to be aggressive with prostatectomy. This would not be somebody, of course, that you would put on surveillance. But knowing now that he's got a GPS of 42, puts him on the right side of the bell curve, you really might want to consider further treatment intensification in this patient. And so what it looks like here is they chose to do adjuvant therapy right up front instead of waiting for salvage therapy with radiation, and then 6 months of ADT on top of that. So it's not in the deck, but I wanted to share with you real quick how I used this in my own practice in one of my patients with a high-risk disease. He was an 84-year-old guy. And the first thing you might be thinking is, why in the world would you even be biopsying an 84-year-old guy in the first place? Well, this is a guy, he's 84, but his parents both lived well into their upper 90s. And this is a guy who worked out on the farm every day, very physically active. And his PSA, we were monitoring it for years. And finally, it just got to the point where I'm thinking, you know what? I never thought this guy would ever die from prostate cancer. But as his PSA kept going up and he was getting healthier as he was getting older, I said to myself, you know what? Maybe we need to be more aggressive in finding more information about this guy. So his PSA had gone above 20. Well, I did biopsies on him, and he was Gleason 3+4 equals 7. But he was a high-risk patient because his PSA was above 20. And you can say whatever you want about that, but technically NCCN high risk. I did a GPS on him because we were talking initially, even maybe not doing anything with this guy because he's 84 and Gleason 3+4 didn't really worry me that much. Well, got his GPS and his GPS was like 68 and he was on the far right end of the curve. He was well above the 40 cutoff. And so based on that information, we decided to give him external beam radiation plus 3 years of androgen deprivation therapy. And without having that GPS information, I don't think I would have ever come to that conclusion. And I really believe we did the right thing for that patient. So I think that's just another example of where it can be useful in a high-risk group. So I'm going to pause. I think that, yeah, we have about maybe 8 minutes left. And I'm going to stop sharing my screen here so we can go to the full screen. And Erica, are you on board?
I am. And it looks like we did have a question come up in the chat. And so, sorry, excuse me, guys. My DoorDash just got delivered. I'm having a late night dinner. So the question is, previously systemic prostate biopsies that were negative led us wanting to know more about whether a cancer was missed. That makes Confirm MDX more relevant. But in the era of MRI with targeted biopsies, a negative biopsy is more reassuring. Doesn't that make Confirm MDX less clinically useful?
Well, to me, the answer is no, because I think that MRI has its drawbacks, as I showed you. I mean, just because it's a high PIRADS lesion, even in particular, and it directs you in that area, it doesn't mean that that's necessarily going to correlate with a clinically relevant prostate cancer. In many cases, it will, but not always. And to me, it's worth it to use all the tools in the toolbox that we have. Why not? I guess the question would be, why not use it? If you do MRI targeted biopsies, use that tissue and send it for confirm if it's negative. See if there's any methylation that's living nearby. And that may be, giving you additional, because otherwise, I mean, you know what happens to these people? They get 5 MRIs, they get 5 biopsies, and you just keep looking for something that's oftentimes not there. And that's cost, that's morbidity. You can biopsy someone's prostate maybe 2 or 3 times, but after about 3 times, they start to look at you and say, come on, doc, now, really, doc, this is getting old. And if you really want to get a little bit more comfort with it, then I think that the Confirm really does that for you.
Any other questions I can give everybody if you want to raise your hand or put it in the chat. And I can also, I'm going to steal the host duties back from you, Dr. Sellinger.
Oh, please, yes.
Right. And then if anybody would like to come off mute and ask a question, I can also unmute you. Oh, no takers?
No takers.
All righty.
Well, we had a lot of participants tonight. I appreciate everybody being here. And I know that the folks from mdxhealth are real proud of their tools that they have. And I hope that you can find some utility in your practices to use these tests. And again, we didn't talk about Select tonight, but that's also out there. And your local reps can help you with figuring out how to best incorporate that into your practices.
Absolutely. Absolutely. Well, thank you so much, Dr. Sellinger. We really appreciate you taking the time. For those of you, if you have any other lingering questions or anything, please feel free to reach out to myself or your local representative. We're happy to share the slides, and this is recorded, so we're happy to share the recording as well. So with that, I thank everybody for their time, and everybody have a wonderful night. Thank you.
Thanks.